Every member of the Hospice interdisciplinary team has unique skills that are essential to the care of hospice patients and their families. Today, we're talking about the best ways to utilize the entire hospice team. You're listening to Heartbeat from the Heart of Hospice. I'm Helen Bauer, here with Jerry Fenter.
Whether you're a family caregiver or an end-of-life professional, we're here to enhance your hospice experience by connecting you with information you can use about end-of-life care. Because we know how busy life can get, Heartbeat is designed to give you helpful information in a bite-sized format. At the Heart of Hospice, we're always looking to connect our listeners with resources and services that can enhance their hospice experience. If your company provides a service for hospice patients or hospice agencies, the Heart of Hospice would love to partner with you to expand your outreach. To discuss customized sponsorship options, send an email to host@theheartofhospice.com. You want your clients to have the best hospice experience possible, and the Heart of Hospice can help you make that happen. Now on to today's episode. So did you know you're on a team?
I am.
You are. You're on a team, not a sports team, although I'm going to use a sports team metaphor for this.
No.
What would it be like if you had a football team and all the players were quarterbacks?
I have absolutely no idea. You know, you're asking the wrong person. You're going to have to answer your own question.
Well, let's just say that it wouldn't be good. You can't have a football team made up of only quarterbacks, or a football team that's made up of only linebackers or centers, or it just doesn't work that way. You need everybody on the team with different skills and a different skill set. So the same thing is true of a hospice interdisciplinary team. Everybody has their own skill set. Everybody brings their unique talents to the care of the patients and the families.
So let's talk about what interdisciplinary means. It's a big word.
It is. Did you look this up?
I did.
Good.
I have it written down, of course. So interdisciplinary means combining or involving two or more professions, technologies, departments, as in business or industry. So we are an industry, and hospice agencies are a business. We don't like to think of ourselves that way, but we are. And we do combine these different disciplines, nurses, physicians, etc. And we're going to talk about each one of them and sort of what gifts they bring and skills they bring and why it's a good idea to allow that particular discipline to be part of the care that you're receiving or your family members receiving.
Sure. So the IDT, that's kind of our slang or acronym for interdisciplinary team, is IDT. Mm-hmm. So the IDT for hospice are composed of nursing clinicians, mm-hmm. Physician, social workers, spiritual care counselors, also known as chaplains, bereavement coordinators, volunteer coordinators and volunteers, the hospice aide, and nurse practitioners.
Right. And we say nursing clinicians because under regulation, there are core members of the team, and the registered nurse in the United States is part of the core team. But we also have LVNs. So we have not just one nursing clinician, we have a couple of types.
Right. So the interdisciplinary team is really part of the hospice philosophy. It was begun way back when the hospice, what we call the modern hospice movement, started back in the 50s and 60s.
Yes.
So the team is made up of different types of providers because we want to care for the whole person. And the whole person involves not just the patient, but the patient and the family, or as I like to tell my team members, the patient, the family, and whoever the patient calls family.
Exactly. It may not be blood family, but it's, friends like family. So we want to care for the whole patient, body, mind, and spirit. You have to have more than one discipline to be able to do that. The best outcomes for your hospice experience happen when you use the whole hospice team.
That's right. So let's talk about the hospice team and kind of give a little bit of an overview of what each one brings to the team and to the care of the patient. So let's start off with the nurse.
The nurse. Ta-da.
And so here's what we will say about the nurse. You can't refuse the nurse.
You can't live with the nurse, but you don't want to live without her.
This is right.
So the reason we say you can't refuse the nurse's visits is because out of all of the disciplines on the team, all of the visits you could possibly receive, you can refuse care from everybody but the nurse. The nurse is the bare bones basic that you have to have because it's required by regulation for the care of the patient. The assessment has to happen. So, an RN is going to be usually the primary nurse, and then an LVN might see a patient as well. But that's all those clinical needs having to do with medications and disease trajectory and disease progression, things like that. That's what the nurse is involved in.
Okay. So
and coordinating with the physician. Coordinating with the physician is super important.
Right, absolutely. So the chaplain is a part of the team that actually can be declined. Their services can be declined by the patient's family.
That's true.
We don't encourage that, but we know that there are some families who just do not want to have a chaplain or a spiritual care counselor involved in their care, and that's definitely their right to choose that. So we would encourage you to do that because even if the chaplain doesn't share the same faith or belief system that the patient or the family have, it doesn't mean that they can't provide good care.
Well, why do people typically refuse having the chaplain or the spiritual care counselor come out?
Many times they say, well, we have our own clergy or we have our own pastor, priest, etc. So here's what I'll say about that. We think it's wonderful and absolutely amazing that they have their own clergy person to support them. We think that's good. But here's what I tell you. The chaplain is someone who has been trained and educated in end-of-life care. And I know from my own personal experience, as well as my experience with other clergy who are not chaplains, that we do not specialize in end-of-life care as pastors and community faith leaders. That's not generally something that we have a specialty in. The chaplain on a hospice team specializes in end-of-life care. That's what we do. And we know what to expect from end-of-life care. We know how to educate about end-of-life care. We know what needs to be provided for end-of-life care. And so we discourage you from declining to have the chaplain as part of your team.
Well, it's not an either or. We have a priest or an imam or the Buddhist monks from our temple to visit, so we don't need the hospice chaplain. You can have both. There isn't any reason the chaplain would step on toes. Your personal faith leader can do whatever rituals, sacred readings, music that you would need. And then the chaplain's also there to provide support for grief and bereavement, which is their specialty. When you're planning your next event, keep in mind that the hosts of the Heart of Hospice podcast are available to speak at conferences and meetings. Whether you're meeting in person or virtually, we can provide education to your team on topics such as how to have compassionate conversations, how to recognize personal bias, building listening skills, and managing personal grief as a hospice professional. We'd love to encourage your team and remind them why the work they do is so important. Because we both have a personal hospice journey in addition to our years working in end-of-life care, we can also share a message of resilience and hope at your agency's next memorial service. To find out more, contact us at host@theheartofhospice.com. We'd love to be a part of your hospice journey. Now back to today's episode.
The aides are next.
Right. So the aides visits are to provide personal care for the patient, right? Do a little bit of tidying, changing linens, helping the patient get a bath, things like that. But the real reason you want to utilize that is maybe the caregiver is managing all of those things. But if we could ease the caregiver burden just a bit by allowing the aide to come in, even if it's just a couple times a week, give them a chance to see what your system is, what your processes are. I know from personal experience, you get these little tricks and habits that you use in the care of a patient, and you don't want everything to be changed up. You don't want somebody to come in and say, oh, we're going to fix all this. We're just going to do it differently. Well, the hospice aide is there to come in and see how you do it and then to continue these good habits, these things that have been working, and of course incorporate safety, etc. And again, that's another set of eyes on that patient to report back to the nurse to let the team know if something's going on.
Absolutely. So let's talk about social workers.
Our problem solvers.
Absolutely. They are the problem solvers. And social workers, like the chaplains and the aides, can be declined by the patient and the family.
Right.
But again, why would you want to do that if you've got somebody who's there to help you, support you, encourage you, and to help solve some problems that you have? Why would you want to decline their services?
Right.
So social workers come in to help support the caregiving system. They are the ones who recognize when the caregiver burden has become overwhelming and can come in and say, hey, let's see if we can get you some help.
Right. Let's talk about what respite care would look like for you.
Right. And many times people say about the social workers, well, they're being very nosy. They're asking questions about our finances or things like that. Well, that's how they find out what resources are available to you, is by asking about your finances, because there may be that you don't qualify for some provider services, but you could qualify for others. Again, depending on your financial situation.
Well, and patients and families don't have to answer any of those questions.
This is true.
If you don't want to disclose anything about your finances, just say, we choose not to disclose that. We're doing fine and we're not interested in a resource where we have to qualify financially and disclose that information. There are a lot of other ways the social worker can help you. And we really would recommend this. This is a system that's made to work all together. And if you leave a piece out of it, it does weaken the quality of life and the quality of care that the patient has.
Okay, so I want to stop going through our list for just a moment, because you hit on something that we probably need to describe as well. You've often described the services of the IDT as a wheel with the spokes.
Yes.
Talk about that, please.
So if you picture it as a big wheel with a smaller circle in the middle, the patient and the caregiver are each two circles in the middle that overlap. That overlapping section, that's our unit of care, right? The patient and whoever the patient considers family at the center of everything we do. And then the spokes of this wheel include so many different disciplines, all the core disciplines, and then the aide, the volunteers, volunteer coordinator, bereavement coordinators, in addition to people like the intake folks, the marketers, because they are the people who give the first explanation to the family and the patient about what the care would look like. Any administrative professionals who help with our billing and who manage our medical records. And if a family requests medical records for whatever reason, those administrative professionals are the people who process that. Our quality assurance folks, our clinicians who do our chart reviews to make sure we're doing everything correctly. But if you take one of those spokes out, you've got a wheel that's off balance. It's the equivalent of having a flat tire.
Exactly.
It is. So wherever you have the blowout, wherever the nail inserts and that section leaks out and becomes soft and useless and that you can't run on it for the tire, really the whole tire deflates. Right? And the car's not going to run as well. So really the best care of the patient happens when all of those team members are utilized. And I understand there are times when an aide visit is just not necessary. So say you have 24-hour around-the-clock caregivers who are paid to come in and out, and they do the patient's personal care, etc. So maybe you don't need an aide in a situation like that. Right. But most of the times, most of the situations I've seen in my experience is having those disciplines, utilizing all the different disciplines that support the patient and the family makes such a difference in the energy level, in the quality of care, in the satisfaction with the whole experience. When the family gets to the end of everything and they can say, I'm so glad we did all this. I'm so glad all these pieces were here. I don't know how we would have done this or this or this without that support of that particular team member.
Right. So just keep in mind that the wheel was created specifically for each team member to provide that specialized support that they give to the patient and the family. And so taking out one of those sets doesn't necessarily mean it's going to work better. In fact, it may not work as well.
Well, we're not necessarily interchangeable.
True.
Right?
True.
There's a lot of stuff that nurses know how to do. We have limited training on psychosocial and definitely on spiritual stuff. We have limited training. But there are a lot of nursing things that social worker and chaplain can't do. The aide can't do nursing things. They can't give medicines, change wounds, or provide education. So the team members aren't interchangeable. We do have unique sets of skills.
Right. Not everybody's a quarterback.
Exactly.
Exactly.
I even understand that part.
Right.
So
right.
let's talk about volunteers.
Okay. Volunteers are those people who obviously are not paid. They volunteer.
Yes. And thank you, volunteers, for what you do for us.
Love our volunteers. So they come in and do things that are outside the scope of practice of the clinicians and the other licensed team members.
Right.
They can do things like maybe giving a haircut.
Exactly. Or walking the patient's dog.
Yeah, sure. Things that are, are time consuming, but things that the other team members can't do or don't have the time to do.
Right. I would have loved to do things like that, to cook a meal for a patient or a family, but that's not part of what the nurse does, nor do we have time in our days for those things.
Exactly. So the nurse practitioners and the physicians are people who can make visits that are required by regulation.
Right.
What we call face-to-face visits, but they also provide an additional clinician assessment. So they come in, they see the patient, and they assess the patient's condition at that present time, many times to determine that they still qualify for hospice benefit.
Or sometimes they'll make a visit if there's something unusual going on, especially for wounds or rashes or things like that, where you really want a second set of eyes, especially if they're going to be prescribing a treatment or a medication. Yes. Definitely, that extra set of eyes always helps. And I will say this, when it comes to utilizing all the members of the interdisciplinary team, it's really even more important for a patient and a family to utilize everybody when the patient's in a facility.
That's true.
Okay, and I realize during the pandemic there have been limitations on that. But in whatever the new normal is going to look like in normal times where there's been unrestricted access, when all the hospice team members can go in and out, it's really a good idea to have additional hospice members, team members, seeing a patient and communicating with a family when they can't be there.
Very good point.
Yes.
Very good point.
Yes.
It does make a difference when you have more than one set of eyes coming in.
Absolutely.
To see the patient.
And it's not just a set of eyes to look at the patient clinically, but to look at the caregiving that they're receiving there from the facility staff. Mm-hmm. Is the patient clean? What does the environment look like? Has the patient lost weight? All of that stuff is very important.
Definitely. So finally, the bereavement coordinators. They bring specific skills that help the family to manage the grief needs once the patient has died.
Yes.
So they often can be declined, but we again encourage you not to do that because they are there to really help in case that there are some complicated grief needs. So be sure to use the whole team because the whole team is there for the whole person.
Thanks for listening to Heartbeat from the Heart of Hospice. I'm Helen Bauer with Jerry Finter. Because we know your hospice journey is 24/7, you can always find us at theheartofhospice.com. Subscribe to the podcast wherever you're listening and leave a rating or a review on Apple Podcasts.
To connect with us, you can always send us an email to host@theheartofhospice.com. And you can also find us on social media. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.